today to listen and to ask questions. The Geriatric Medicine Seminar Series is brought to you by the Australian Frailty Network, as well as the Queensland Dementia, Ageing and Frailty Clinical Network. Today we are very excited about this topic. I think it will be interesting and clinically useful to so many of us, and it's about frail older adults who are in the prisons. We have three excellent speakers today. Each speaker will have about a 15-minute presentation, and then we will have time, hopefully, for some good questions at the end. So please write down your questions. You can pop them into the comments box, pop your hand up towards the end if you have any burning questions at that time. I'd also just like to remind everybody that we kindly ask that you don't use any external software to record or transcribe this webinar. If we notice any unauthorised recording, we may have to remove you from the session. So thank you for your understanding and your cooperation today. So to get us started, I'd like to welcome Dr. Jane Hwang. Jane is a mixed methods researcher who's interested in tackling health equity and social determinants. She leads a suite of NHMRC-funded projects which seek to understand and respond to the ageing of justice-involved individuals in Australia through a variety of methodologies, including longitudinal cohorts, digital tool design, and stakeholder consensus building. Thank you, Jane.
Thanks. Yes, I'm off mute. Okay, thank you all very much for being here. Can everyone hear me? Okay, great. I won't talk any more about myself, but I did also want to mention other people in our team who contribute to this work, and especially our great government stakeholder partners in corrective services and justice health as well, who are involved in our work. So I wanted to add my own acknowledgement of country. So I live and work across unceded Bidjigal and Gadigal land and Badigal land as well, and pay my respects to the elders of First Nations communities on those lands for the custodianship of the land, and to extend my respects to anyone who is First Nations here today, especially noting the extensive impact of ongoing institutionalisation and hyper-incarceration on Aboriginal communities as well. All right, so today I'll take you through 3 points, those being why should we care about ageing in prisons, what do we know so far from a research perspective, and what's being done focusing on our little group here at UNSW. Being who I am, I will, I guess, provide the information from a really public health research perspective. So why should we care about ageing in prisons? They are rapidly growing, so the rates of ageing in prisons are actually faster. It's outpacing the rates of ageing in the general population at the moment, with up to 1 in 5 people in Australian prisons currently considered older. This group really come with all the social determinants of ill health that we might expect in people who are involved in the justice system. But when we further compound that with age, we do end up seeing really high rates of illness, multi-morbidity, also accelerated aging, which I will talk about a bit more later. But at the moment, there is universal consensus that in the prison setting, if you're 50 plus, you're considered older. And it's even a little bit lower for those who are Aboriginal or Torres Strait Islander as well. Prisons at the moment are unfortunately just really not ready to take on an ageing population. So staff really lack the training and the resources to take care of a group that are about the built environment of the prison and the social environment of prison. It can really be this kind of fight for survival in a young man's jail.
A meeting that I'm at.
Caring for this group in particular entails really high costs. So our group did some modelling a few years back that suggested if the age trends continue the way they are, the cost of health expenditure, which is already rising quite steadily, could increase by a further 70 to 90% within the next 10 years. Also, I think when we think of people in prison, there's a tendency for this sort of us and them mentality, but it's important to remember in Australia that most people will be released, and thereby the high burden of illness and care and associated costs are transferred to the community. Then, unfortunately, once they are released, they tend not to adjust very well. So we find a lot of poor outcomes in literature in terms of social isolation, rapid health declines across all areas, and also a risk of returning to prison as well. So hopefully what's really apparent here, a bit of a grim picture. There's a really rapidly growing group who experience quite significant intersecting disadvantage. And there are widespread implications of this, not just for public health, but also for human rights, for social justice, as well as crime. So I'll cover what we know so far in terms of the research. The literature is fairly young. So prison aging as a topic sort of only really became a thing in the early 2000s or so. And so what we know so far mostly comes from the US, which is unsurprising since they do have the highest imprisonment rate in the world. But this systematic review showed us that up to 2017, there are only about 100 studies on the topic, the majority of which came from the US, smattering from UK or Ireland, and only 7 Australian studies at the time. Since then, there have been about 10 more, mostly qualitative studies and reviews, commentaries, etc., on some relevant challenges that face this group. But importantly, in 2020, the Australian Institute of Health and Welfare come out with this report on the health and ageing of Australia's prisoners. But overall, what this means is that most of what we know about this population in Australia in terms of health data, at least really comes from 2 main sources. The first is a collection of 5 studies, which were part of that 7 in the systematic review. And they all come from one cross-sectional study from about 10 years ago on 173 older people in Victoria and New South Wales. And they all focus on psychological distress as measured by the K10. They did find high levels of psych distress. It's about 3 times what you would expect in the general population. But they really went on to show how this psych distress comes from essentially navigating the prison environment as an older person. So it's social and physical barriers. They also importantly found that 50% of their sample had a record of a mental health diagnosis, as well as having on average 4.32 health conditions listed on their files. So significant multi-morbidity. The second source is this report by the AIHW. It's based on the National Prisoner Health Data Collection, which looks at people entering prison and also takes a snapshot of the use of prison health clinics as well. And I think the prominent messaging that we get from this report is that older people have a unique health profile compared to the younger people. So they are almost twice as likely to have a diagnosis of any of these key chronic conditions, with almost a third reporting having at least one of them. High rates of polypharmacy, therefore taking more medications than younger people. They tend to self-rate their physical health lower than the younger people. Also, in the year prior to entering prison, they're more likely to have had higher alcohol consumption, but tend to have lower tobacco or illicit drug use compared to the younger people as well. They're less likely to have a mental health diagnosis or be taking a medication for mental health compared to younger people, but similar to their self-reported physical health, they have lower self-reported mental health as well. And understandably, they tend to use the prison health clinics more than the younger people. So it really seems like their health profiles, it's geared more towards that chronic disease and accumulated health deficits type of flavour compared to the younger people. So drawing more broadly from the international literature, there's consistent evidence basically of markedly poorer health compared to people in the community. I briefly mentioned that there's evidence of accelerated ageing, and this study found that people in prison had age-related impairments like urinary incontinence, hearing impairments, mobility impairments, that were at rates similar to those who were 15 years older than them in the community. So we're not just seeing higher rates of disease, but also an earlier onset of these as well. This is from a meta-analysis focusing on psychiatric conditions. So it found with a pooled total prevalence of 38.4% for any condition that people had elevated rates of nearly all conditions compared to those in the community. A number of studies also find functional impairments in activities of daily living. This is both for people who are currently incarcerated and also people who were previously incarcerated tend to be at risk of developing impairments at a higher rate. Cognitive impairment and also relatedly dementia it's interesting. Many people agree that this is a significant concern for this group, but there are surprisingly sort of few big studies on prevalence, and the rates seem to be quite different. So over these 3 studies, mild cognitive impairment appears in between 13 to 25% of people. But either way, it's very high. Just moving on to what I think are some of the key challenges and gaps that exist, a big one being the likely under-detection of health conditions. So regular health screening doesn't really tend to occur. There's obviously reception screening. A lot of it's focused on getting, a snapshot of the acute needs of people coming in. There isn't really good comprehensive screening that occurs during imprisonment, except really at the discretion of prison health staff who might notice a need here and there. Really, though, I think the reality is that prisons are a low resource setting. And I think there's also partly this sort of security versus care tension that feeds into that as well. Also, health records can be lost or forgotten during the transfer in and out of prison, which is an ongoing issue that tends to come up. Also mentioning some post-release challenges for this group. I did mention they have a range of issues adjusting. I think they come a lot from undoing the often many years of institutionalization that they've experienced, breaking out of that the prison routine. Health literacy, in the same vein, is not great. They haven't really had to exercise health literacy. Digital literacy is a really big arising issue, if you can imagine having been released after even 5 years and being asked to do online forms or scanning QR codes. It's quite difficult. The care transfer to the community is currently not, I don't think it's built in very well to current practice. And of course, they face a lot of stigma and ageism. I think it's also related to the fact that a lot of the older ones are in for sex offences as well. So there are still really significant gaps in terms of research. I wanted to highlight women and First Nations. They are a minority within the population, but they have a unique profile of need that I think we don't understand very well yet. Also, we need longitudinal studies that can really tell us what's happening over time during a person's imprisonment and afterwards as well. And similarly, we're yet to see any really, trials or theories or interventions that focus specifically on the needs of older people. And finally, to point out that by now it's probably bleedingly obvious that we have a group who you would expect to be at higher risk of frailty, that might come on a bit earlier, perhaps also deteriorate more quickly. They're in an environment where they don't have many equitable opportunities to assess that or to care for it. But we don't really have any data that's been published on this as of yet. So for the last few minutes, I'll have to rush through, very briefly touch on some of the projects that we're running here at UNSW that are trying to fill in some of these knowledge gaps. The first one is a cohort study. So we've been able to get some funding to set up basically the first prospective cohort of ageing in prison. We're focusing on the prevalence of frailty and looking at a range of age-related health conditions. You can see the questionnaire domains on the right. We want to compare their health to the community. We want to look at how much their health changes over time. Does it stay stable? Does it get worse? Does it even improve perhaps in some groups? And whether different subgroups might exist in terms of the way they would deteriorate as well. So we're hoping for 3 waves over 2.5 years, looking at 650 people in New South Wales prisons. The age cutoff for this one is actually 45 plus, and we'll compare to 400 people in the community. We're really in the trenches with ethics for this one at the moment, but we're hoping to kick off by the end of the year. Data collection. The next study is the ESCAPE study. This is an ideas grant, and the problem that we're trying to tackle here is that health screening, data collection in a low resource setting, also the fact that a lot of this group have really low literacy. So we've developed so far a prototype of some screening tools, which are essentially iPad delivered apps. And we're hoping that they will capture really valid age-related health and cognitive functioning data with minimal supervision, so the person can sort of do it themselves. There'll be 3 phases to the study. We've done some co-design focus groups to produce the prototypes. We're currently just kicking off user testing with a group of older adults in the community just to make sure it's usable and nothing's really wrong with it. And then we're taking it into 150 people in New South Wales prisons, hopefully by the end of this year, to see whether they think it's acceptable and whether the data that's coming out is valid as well. So there are 2 sub apps that sit within that escape. The first is the health survey, and it's built on collecting a frailty index and a DEM NCD score as well. The point of this really is that it can be self-completed on a touchscreen device. It's everything, all the text is delivered in an audio sense, as well as all the buttons as well. Everything's very visual, and we're hoping it will only take 25 minutes to complete, but we'll see. The other component is the cognitive screening app. It's essentially 10 mini games, like brain training type games, again, touch screen, self-complete, and we're trying to screen for the presence of some select cognitive impairments as well. I've completely run out of time to talk about these projects, but just to illustrate that there is a bit of work also happening in the release and reintegration space. I've mentioned health literacy, digital literacy. We also did some priority setting with different stakeholders from different sectors about how to improve outcomes for this population. Take-home messages. I like to tell anyone that will listen that prisoner ageing is everybody's problem, but nobody's job at the moment. What we need moving forward, I think, are approaches that are preventative, holistic, and equity based. I think to progress, there will be real value in rethinking that security and care balance or tension, which is a complex issue and obviously won't change overnight. But interest and engagement from broader circles of people like yourselves and people in the community outside of the prison walls will be really valuable for progress. So thank you very much. I'm sorry that was so rushed.
No, thank you, Jane. That was fantastic. And certainly people will be able to know where to go looking for extra information and work that your group is doing down at UNSW. Our next speaker is Hayden. Hayden, are you there? Where is he? Hello, Hayden. You're going to share your... How are you? Well, thanks. You're going to share your slides, aren't you?
Yeah, sure.
Super. Hayden is a clinical nurse consultant. He has been a primary healthcare nurse at Prison Health Services in Westmoreton Health for 10 years and is currently pursuing a Masters of Research with a thesis focused on older people and incarceration, the challenges faced by nurses caring for older adults in prison. Thank you, Hayden. Over to you.
Thank you. I would like to acknowledge the traditional owners of our lands on which we operate, the Jagera, Yugara and Yugarabal peoples, and we recognise their contribution to health of this space, their custodianship of the lands, waterways, skies and all that live in it. Good afternoon, my name is Hayden. Before I started my nursing career, I came from hospitality and quickly realised that my passion was more helping people more directly. So then I transitioned to healthcare into a personal care worker in aged care facilities. I found that I love supporting people, making them feel comfortable and valued, particularly caring for their final stages of life. This led me to complete my enrolled nurse qualification through TAFE and then my Bachelor of Nursing at university. I then worked across aged care settings and eventually becoming an aged care funding coordinator. And then I moved into prison health services to expand my clinical skills. And I've worked in various roles over 6 adult correctional centres in the past 10 years. My career journey has made me passionate about addressing health disparities, particularly in this case for older Australians in custodial settings. Currently, 1 in 6 Australians are classified as older, and thanks to medical and technological advances, life expectancy has jumped more than 20 years over the last century, according to the Australian Institute of Health and Welfare 2021. However, one area that's been overlooked is the ageing prison population. Since 2009, the number of prisoners aged 45 and over has risen by 79%. Older prisoners typically experience age-related conditions 10 to 20 years earlier than those of the general community, making them a vulnerable community group that requires specialised care. Sorry, Dr. Jane already told you all of that previously. Unfortunately, ageism within the system significantly impacts the quality of healthcare older prisoners received. Many experience inadequate treatment for severe conditions, even when medical attention is needed. Systemic barriers like overcrowding, long waiting lists, and staff burnout mean prisoners can wait months to see a nurse practitioner or a doctor unless it's an emergency. Prison operations such as strict movement protocols also prevent easy access to healthcare. In some facilities, nurses will travel 2.5 kilometres per round to deliver medications. Historic models of care are struggling to meet the health complexities, and the workforce often feels unsupported. This environment compromises the dignity, health, and well-being of ageing prisoners. The aged care quality standards in the community provide a strong framework for what good care should look like. Key focus areas include dignity and choice, and that's respecting the autonomy of individuals, ongoing assessment, regularly reviewing and planning care around the individual's changing needs, personal and clinical care, ensuring people's daily living and medical needs are adequately met. My research aimed to explore how these standards are being upheld for older prisoners compared to those in the community. Specifically, we asked, how does compliance with the standards differ in prisons compared to aged care in the community? Do older people in prison maintain their dignity and choice? How is assessment used to inform care delivery? And finally, is personal care and clinical care tailored to their specific healthcare needs? We used a qualitative methodology to explore these questions using semi-structured interviews with nurses. We aimed to interview 12 nurses, but due to time constraints, we completed interviews with 8. The interviews were open-ended, centred around the key aged care quality standards. We analysed the data using thematic analysis, following 6 structured steps: the familiarisation, immersing ourselves in the transcript, coding. We organised data into manageable pieces. Then we did theme exploration, identifying patterns. We refined and defined relationships between the main themes and sub-themes. And while final discussions are still underway, the 5 key themes that we've begun to emerge include essential insights into dignity assessment and the challenges nursing staff face. The first theme is governance, prison environment, systemic limitations, and institutional power. Qualities and competencies of a prison health nurse, barriers to delivering age-specific care in prison, suggestions to improve aged care in prisons, characteristics of the older patients in prison through to end of life. Ultimately, ensuring the well-being of older prisoners is not just about meeting basic health needs, it's about honouring their dignity, protecting their rights and advocating for equitable care. Thank you for your attention, and I look forward to your questions. Thank you.
Thank you, Hayden. Well done. Such a massive amount of work that you're trawling through at the moment, for sure. All right, and that sets us up nicely for our next speaker, which is Karryn. Karryn, am I sharing your slides for you?
Yes, please.
Yes. Okay. Let me get that up for you. Second. Is that working?
It is. It's on, yeah, it's presenter. It's not on presenter mode.
It's not on presenter mode. Okay, hold on a second. Sorry, everybody. What about now?
Karryn, if you just, you know how it says display settings at the top of the,
Yeah.
and then switch that to swap present. That,
How's
there
that?
we go.
That's
Beautiful.
thank you.
Super. Thank you.
Okay.
And now I'd just like to hand over to Karryn. Karryn is a senior social worker who works out in Westmoreton as well as part of the geriatrics department, and has extensive experience in navigating the aged care system alongside some of our most vulnerable incarcerated older patients. Thank you, Karryn.
Thank you. So it'll be a slightly different pace to Jane and Hayden's research. This is just some reflections on working to transition 2 gentlemen living with dementia from prison to residential care. Could I have the next slide, please? Just a bit about my background. I'm a social worker. I've worked for 21 years in the dementia space. 17 of those years have been in the community space in various roles. I currently go into people's homes and work with them following referrals from the geriatrician outpatient clinics. And I work in a disadvantaged community, so I'm quite fluent in the social determinants of health and wellbeing and intersectionality as they relate to dementia care. And it was great to see Jane reference those very important considerations. So in terms of my approach, the things I prioritise are good process, communication, relationship-based care, supporting agency for people living with dementia, using supported decision-making rather than substitute decision-making where we can, and an approach to risk and autonomy where I would describe myself as not risk-averse, and I'm mindful of the risks that come with protections and institutionalisation as well. Next slide, please. So the 2 gentlemen that I was involved in placing, the first gentleman was 90 years old. He was nearing the fixed release date for a 10-year sentence, and with the fixed release date, you're actually placed out onto the pavement on the day of release, regardless of the plan. So he was diagnosed with dementia during his imprisonment, staged as moderate, and he had some mild neuropsychiatric symptoms around suspicion. He did not have any informal support people. He was in the community. He was placed in a protection unit with one of the other prisoners who was younger, providing him with some cares. My contact with him was via Teams, which was particularly tricky because he had unmitigated hearing loss. And we established during some of those discussions that he had a history of childhood trauma, which is relevant in the dementia space, particularly around the expression of changed behaviours. The second gentleman was 83 years old and he had been on remand for 2 years. His situation was legally complicated because he wasn't fit to plea. He'd been diagnosed with dementia prior to imprisonment, and it was now staged and advanced, and he had neuropsychiatric symptoms and changed behaviours along with functional changes of some significance. This gentleman had a supportive wife, but she lived interstate. He'd been removed from another state to come back and face historical charges. He was cared for in the hospital prison unit by an AIN. I did not have any direct contact with him, and his wife was his second wife, so nothing was really known about his childhood. So neither of them were gentlemen who'd been incarcerated earlier in life. They were both later life incarcerations when their victims of their earlier offending gained agency. Next slide, please. So there's 7 issues that I identified as somewhat different to my day job. One of them related to sensory deficits. That in itself is not unusual, and I won't speak to it all, but we know that there's a lot of ways in which sensory deficits contribute to loss of quality of life and confusing experiences of the environment for people living with dementia. But in prison, it can also increase their risks of experiencing conflict or violence through that misinterpretation. So some of my observations were that this was more of an issue for the long-term prisoner. The gentleman who was on remand had actually been had community GP care and also community geriatrician care, patient care, and so some of those issues had been mitigated, but it may have been that they required further mitigation as he aged. I was surprised to discover that prison staff didn't have access to assistive devices such as amplifiers. And of course, that was really interesting to see it play out. It made it difficult to do assessments, but also for the longer term prisoner, his hearing was very poor. And I noticed that in our discussions and his discussions with the nurses as well in prison, that he declined interventions. When we used an amplifier, once he was in residential care, he actually agreed to those interventions. So you can see his unmitigated sensory deficits did have impacts on his health literacy and his health outcomes. So one of my observations is that we need to have interim management plans for people on their release until sensory assessments and assistive aids can be accessed. And in that gentleman's case, it was as simple as a whiteboard. We knew he could still read. We tested that out. And I borrowed the toddler amplifier from the audiology department as a way of getting around that until it could be resolved. Next slide, please. Another observation relates to the way that dementia assessments are done. Holistic dementia assessment is an acquired skill set, and I found it really difficult not being able to go in and meet these gentlemen. So I found it challenging to rely on others for feedback. There is a high turnover of the nursing staff and they've got a lot of demand on them. So that impacted progress at times. I was needing to negotiate with the next nurse when I was coming back for information that was going to be sourced. I often had to restart again, so it made things a bit slower. I was able to negotiate to send some written questions through to the prisoner who was caring for the longer term incarcerated gentleman, and that revealed some delusional content that the staff did not know about. So I guess part of the learning there was that for any future interface with the prison system, I will be insisting on face-to-face access to the person living with dementia so that we can have better assessments and better planning. Next slide, please. Another observation related to sourcing residential care. Now, we already have a lot of challenges with sourcing residential care for people in the community, and some of the issues for the southeast corner of Queensland is that demand is outstripping supply, so we have a lot of people waiting in hospital for residential care. Residential care facilities are often speaking to an increasing lack of confidence in managing changed behaviours in dementia. And there's also a distinction between those who own a home that can be sold to cover their refundable aged care deposit and those that are fully supported by the government. So in the case of working with these two gentlemen, we were looking at intersectionality where we had financial disadvantage because they weren't going to be able to pay a refundable aged care deposit, meeting with dementia stigma and prison stigma. So some of the observations I have about challenging that was attention to detail was really important. I did construct quite detailed written information covering a whole range of things that I won't read out to there, but they're things that are all relevant to residential care facilities when they're weighing up whether or not they can care for someone and how much funding they'll attract, who they'll go to for problem solving. My approach was to be honest. If I didn't know something and had no way of sourcing it, I just had to own that. We needed to be persistent. For each gentleman, I approached over 90 facilities before we found a facility willing to give them a go, and also expect some rejections. One of the feedbacks from one of the largest chains in Queensland was that their senior manager thought it was disgusting that I was trying to place these sorts of people in residential care. So next slide, please. Another challenge was around the issue of managing risk versus privacy. And for those approaches that got beyond, we can't help you out, there were two key questions that emerged very early in the discussions. The first one was what did he do? And I really didn't know the answer to that. I had some information, but it wasn't full information. And I struggled with, do they need to know? And of course, there's an aspect that is relevant to matching to residential care, and that relates to, does this person pose a risk to frail aged residents and to staff? And I had to accept that I don't have a forensic risk assessment skill set, and I wasn't able to negotiate for someone with that skill set to see either gentleman. So my observations around tackling that was that it's important to prepare a form of words, either written and verbally, to provide information that's helpful to the facilities when they're conducting their risk assessments. Bear in mind they have different physical environments. They have other residents who may have quite challenging behaviours or quite complex needs. They need to make those assessments, but we need to be as helpful as possible. And part of that was being informed about the known behaviours for both of these gentlemen and any strategies that worked in prison. I did offer Dementia Support Australia referral and engagement as part of the transition. Neither facility took that up. And I did inform our local, for one gentleman, the local to his facility, the Care Pact team who interface with residential care from the health service. The other gentleman was placed in an area where I could not identify a team. The other observation I'd make is that don't dump and run. I made it really clear I would be available for post-placement problem solving. There were going to be some difficulties because of the nature of the circumstances. So I did reassure them that I would be available, and I was available for that. Next slide, please. The interface of the legal and medical models was more pronounced in these situations. So that for the longer term gentleman who had no family, I needed to do a QCAP process. Both gentlemen had court imposed reporting conditions which needed to be navigated with the vulnerable persons unit in the police because they weren't in the position to self-initiate going off to a police station once a week. For the gentleman on remand, there were a whole range of complicated issues around his fitness to plea and his legal jurisdiction. So he was being managed in the Magistrates Court and there was quite a delay in getting him to the Mental Health Tribunal. With that gentleman, we also needed a bail approval for him to go to care. And even though I had been really clear beforehand with his solicitor that we would need to have him in that residential bed within 7 days of the bed offer being accepted, at the time, she indicated she couldn't deal with that for a few weeks, I should say. So I had to be both assertive and also proactive. And I actually wrote a letter to the magistrate setting out some of the considerations and why this gentleman needed a timely bail response, and we were successful with the bail. There were other little issues like I didn't realise that when a person from prison goes to hospital that no one is notified, no family, and they're not recorded as being in the hospital, and that's for any callers, and that's to do with security, of course, and that was a little bit interesting to tackle because his wife, of course, didn't know that he was in hospital, and I was interfacing with her around the placement offer at the time. I'd also observed that it creates some additional challenges for the medical system, particularly around the special legal considerations. And there was some expectation in the legal system that the health-related geriatricians would provide medico-legal information, which wasn't really the information that they were transacting around. So I think those two systems colliding, some of the ways we navigated that was by communication, by seeking to understand what the professionals and what the systems needed, by being assertive. And I was really grateful for some brilliant guidance from the senior solicitor with the Aged and Disability Advocacy Legal Service. She really helped me to know who to contact and what to consider. Next slide, please. Thank you. There's also a lot of practical issues associated with transition to residential care. So the question is, who sorts that out if there's no family or friends? And some of the relevant observations, when you're in prison, you don't receive social security, so it's not possible to do an assets assessment. And for many facility chains, they won't even put someone down on their wait list until there's an assets assessment. The other thing that happens when a prisoner is released is they attend Centrelink on the day of release to access a prison release payment. But I felt that that would be extremely difficult for a 90-year-old who would also already be dealing with the geographical disorientation that comes from moving to prison to residential care. To take him into Centrelink for an hour and a half would have been just grueling for him. He'd had the public trustee appointed as an administrator by that stage, and I was trying to be proactive. They weren't particularly helpful, so I made some inquiries myself and did an application, found out I could do a paper-based application, and that was submitted so that his social security could be expedited and we could do all of those other things in a timely manner, and he could pay for his care. There's also the issue of clothing. Facilities require 7 days worth of clothing, and I didn't want to send anyone to care in their prison browns. It was difficult to gauge sizes and whether or not the person had pre-incarceration clothing that was still suitable. There's no funds to purchase clothing. In the situation where the wife was able to take care of that, some of that was different, but for the gentleman under public trustee, there was no money at that stage. So I did do some grassroots searching around and find a Catholic program that can provide clothing to prisoners on release, but they need a 3-month lead-in time, and we didn't have that. So we ended up with them donating some clothing and me purchasing some clothing to resolve that. Transition to residential care was important. I took the older gentleman to care, and that actually proved really helpful because during the 50-minute drive, we were able to identify some of his self-soothing strategies and some of his interests. And on arrival, he actually experienced some delusions around a belief that his previous prison inmates had conspired to get his really good room and organised for him to go to this other prison that he didn't want to be at. And all of that work, talking to him online beforehand and finding out about him from this prison carer, and some of that discussion in the car was all really helpful. We were able to settle him because, of course, facility placements often break down in that first 7 days. So it was really important that we could model, problem solve and model for the facility. There was also the issue of not having familiar items to support orientation to a new space. I didn't realise until the day that gentleman, it's possible to store a lot of belongings at prison. We had a carload full of belongings, and so we were able to use that, unpacking that to orient him to his space, but also to find out some more stuff about him. Next slide, please. And this is my final observation. It's around working with undeserving clients. So by virtue of their crimes, these gentlemen have breached societal rules, and even within the prison system, they are subject to some ostracism. And we're certainly seeing that with the residential care facilities as well. Moral judgments and fear are part of this. As clinicians, we intentionally work with all clients from all sorts of backgrounds. We're guided by our discipline-specific values and our organisational codes of conduct. But and I think of myself as a very open person, but working with these gentlemen triggered some moral discomfort for me. Many of the clients I work with have carried the lifelong trauma of experiencing other people's crimes, and so I needed to do something with that to be able to work effectively. And so I navigated it with an intentional focus, and it had 2 prongs. One of them was that it wasn't my job to punish, and the other was that this fitted within my commitment to enhancing quality of life and wellbeing for people living with dementia. And that helped me to maintain perspective. So final slide. Thank you, Emily. So just to sum up, transition to residential care is always a sentinel life event for people living with dementia, and it should always be approached with attention to detail and mindfulness of personhood. But there's some additional challenges when that transitions from prison. And some of the things I found helpful was partnering with other services and providers, communicating, ensuring we just maintained communication. If in doubt, ask a question about it, being proactive and following through. And just the final observation, both placements were successful, they didn't break down, and both residential care facilities provided really good person-centred dementia care to those gentlemen. Thank you. Thanks very much, Emily.
Oh my goodness, Karryn. What an extraordinary stories. Thank you so much for sharing that with us. And perfect timing. So I would like to open up any opportunity for questions for any of our speakers. You can either pop your hand up or pop them in the chat. Yes, Adrienne.
Are we on?
Yep.
Hi, it's from me, Fred.
Oh, hi, Fred.
Hi, it's a question for Karryn, and maybe that's amazing, Karryn. I can't believe that amount of work you've done. I'm a CNC for dementia and delirium who specialise in behaviour in a big hospital, so I absolutely get what that must be like. I had two questions, and it might be open for everybody. But in that, going back to that, assessing the risk to others based on the forensic history in the context of dementia, I mean, I get it that you're not a clinician who might do that as a social work, but were there clinicians around who could do that, or were there tools that you could use to do that? Because it sounds like a big first issue. And then the second question was, how long did you provide transition support to know that they were settling in well? Is it intensive for a week or two, or is it ongoing pop-ins for 3 or 4 months or whatever?
Oh, thanks, Fred. Well, the first question is, I would have gladly handed over those forensic assessments. I couldn't find anyone who would take them on. So I just did what I do in the community space as best I could. I guess it's trickier when you're not interfacing with the person, because I rely on my own assessments a lot. I do have SIMA access, so I was able to look at some of the prison mental health assessments related to the gentleman on remand. And we had a good history, I guess, on the gentleman that had been there for 10 years. There really hadn't been a lot of behaviours identified. So it was probably the part I felt the most uncomfortable with. You know, was I taking on this huge amount of risk, but I couldn't get any traction on support around it. So we just do in community, you just do what you do with what you've got. In relation to the second question, the older gentleman passed away about 5 weeks after he was placed. So that provided an end to that work. But I did go and see him about 2 weeks in. We had a QCAT hearing, and so Care Pact did come on board and provide some really good palliative support to him as well, and that was a really, really positive interface. They saw the person rather than the prisoner, which was great. The other gentleman is actually, I have got contact from his wife from time to time. I did contact the facility for a period of about 5 months later. I'd contact initially 2 weekly and then back to monthly. They weren't having any difficulty, and his wife more contacts me for emotional support occasionally now. So, yeah, so I think that answers the questions.
Thank you. Our next question is from Helen.
Thank you all for some great presentations today, really interesting. My question is to Dr. Hwang. You talked about at the end, and I know we haven't got much time left, but about some work you're doing in terms of digital literacy for some of the people that are leaving prison and their adjustment to the outside world. Can you tell us a little bit more about that? I'd love to hear more, or even if you I'd love to contact you to hear more about what that's about.
Absolutely, get in contact. It was just a bit of qualitative work first exploring the issue because people kept saying it was an issue. And so, yeah, there's a couple of qualitative studies and a conversation piece that was published, which I can definitely send your way. In terms of work, we've been trying really hard to get a grant going to provide some digital literacy training for older people in prison who are getting ready to be released. we have, you know, all this support from the eSafety Commissioner, from the government, to also develop these modules to take them into prisons. It's just no one's willing to fund the actual project yet. So, but we'll keep pressing on. Also, the Telstra Foundation was also very positive about supporting that sort of a project as well. So I will keep on.
Keeping on, yeah.
Yes,
okay, great.
It.
Thank you. I'll throw my email in the chat. Thanks.
Yeah, thanks.
Val, Dr. Lim.
Hi, Karryn. Karryn and I've worked a long time together. I did wonder, Karryn, were these referrals, because I missed part of your talk, did you get these referrals through the clinic, the geriatrician clinic, or was it through the prisons? But then I guess the other question is, it's probably a bit naive, but is there any social workers available at the prisons? And if not, would it be something that, you know, you could, I don't know, whether there is room for creating sort of like a manual or a pathway for people to go from transitioning people with dementia out? And probably the last question I have, do you find that it's easier to move them from prison to nursing home because they're already institutionalized than actually returning to the community? Sorry, lots of questions.
I don't know that I can remember three stages to that, Val. So Hayden was actually managing the older gentleman first, and he approached legal, saying that he had a knockback from QCAT. And it was as simple as the timing. You know, QCAT needs to have a problem that they need to resolve immediately, and Hayden was being proactive. And so out of that, legal misadvised Hayden that a social worker had to do a QCAT application, which isn't actually accurate. But from that, the Director of Social Work asked me to manage the first gentleman. And then the second gentleman came from the prison himself, and it made sense to assist as well with him because he was starting to bounce between the prison and the hospital system. And really he needed a residential care solution. He was too high care for the prison environment. Sorry, what was in terms of placing them when they've come from a institutionalised environment? I think it's very individual. It's difficult to know, but I was surprised that the second gentleman, the one who is still alive now, settled so easily. And I think probably some of that was that he'd come from an institutionalised environment. But he was also going into a residential care facility that had previously cared for prisoners, and so they weren't daunted and they had a proactive approach. Sorry, I've forgotten the third question about.
Oh, it's like, do they have any social workers associated with the prisons? Because obviously your attachment with Ipswich is already a very heavy workload.
Yeah, I think that they're making some provision in the prison at Gatton to include social workers, but that's not going to be an older person's prison. So it is interesting to think about what models of care would be really helpful. I think Hayden's work's really important because it's about raising awareness, and Jane's of course too, but you know, Hayden's right there in the prison raising awareness. And we chatted a lot along the initial work on the first gentleman around some of these issues and what looks different to community-based dementia care.
And
Hayden,
following on from that, I guess, do you have any insights that there's change coming, or there's an appetite for change within prison health or within corrections more broadly with regards to the care of older prisoners?
Well, as Karryn was mentioning, it's just so complex trying to get elderly people into aged care homes. So we're just so lucky to have Karryn helping us with these cases. But before Karryn joined, yeah, it was just the nurses trying to do all these placements into aged care and dealing with the geriatricians in the hospital. Even for anyone in the community, it can be waiting for a year appointment, and then they go from prison to their appointment after a year, and the gerontologist says they don't know them well enough, so then they have to wait another year. So by 2 years with someone with dementia in prison, it can be a long time and they can decline. So that's really complex. However, going from an institution to a nursing home, I think they do quite well, because the nurse unit managers of the nursing home tell me that they've settled in really nice, they're really polite, that they just are just really well institutionalized when they go to nursing home. So I don't know if that's because of their prison environment. Yeah, but they do well in the nursing homes post-release. Thank you.
Thanks, Hayden. And one last question from Fred/Adrienne/ whoever else is in that room.
Yes, it's the Fred Adrian show here. Hey, so Hayden, just leading into that, so I would assume that residential care is much more free for somebody who's been in prison, and that might explain, I mean, as long as the care is good, that might explain that it's just a better place for them to be. There's freedoms, and I mean, I was thinking about Karryn unpacking the fella's belongings and all of those sort of things, and pinning an orientation. Is that your impression too? I mean, that would make sense to me.
Sorry, what was the question? It's more freedom in prison?
Yeah, so the whole environment has got places to have recreation and activity and interaction, and which maybe, I suppose
they do have interaction. They don't really have activities.
No.
They have prisoner carers that look after them. However, we're not sure how that model looks because it's a prison model. It's not really
they
from.
They have that in the residential care facility, prison carers that look after them. No. So that's what I'm saying. It's like, I'm just wondering, it just feels like it would be a better environment, knowing how important the environment is to people with dementia.
In the residential aged care.
Yeah, in the residential aged care.
Oh yeah, definitely. I thought you were meaning residential in prison. Sorry, we've got a residential in prison as well. Sorry. Yeah, we've got, yeah. Yeah, it would be better for our elderly people that are frail to be in the community in nursing homes. Yes, especially with dementia.
But on the other side of things, people with dementia like routines and
yeah.
So prison has that, right? So I'm wondering if you've thought, well, obviously it doesn't sound in the case study of 2 that hasn't been a problem transitioning.
All right, I'm going to bring the meeting to a close now. I'd like everyone to join me in thanking our brilliant speakers, Jane, Hayden and Karryn. You all gave us really different but vital perspectives, and we wish you all the best of luck in your research and in your ongoing clinical work. And I hope you don't mind, you may get a few emails and contacts from people who are interested in helping and getting involved. So we greatly value the work that you're doing. Thank you.
Thank you.
And thank you to everyone for joining us for the seminar, and we'll be in touch about the next one coming up in July. Have a good afternoon. Thank you.